We are in Chicago at ACC 16, and one of the studies being published simultaneously in JACC following this meeting is this one, long-term 3-year data from the core valve high-risk study, and it is presented during a featured clinical research session here at ACC 16 and then simultaneously published. So to talk about it, I'm with Dr. Michael Reardon, who is Distinguished Chair of Cardiovascular Research and Professor of Cardiovascular Surgery, DeBakey Heart Vascular Center at Houston's Methodist Hospital. Now, we've talked a few times before, and previously you noted that you expected to see the greatest benefit in the first year of TAVR, but then found a further separation of the survival curves between 1 and 2 years. So it's kind of exciting. What are you reporting now here at ACC and in JACC?
Well, what we see at 3 years is that there's still a big difference between surgery and TAVR. So the lines remain parallel. They haven't come back together.
Wow.
You know, in any mortality curve, eventually they come back together because everybody dies.
Exactly.
And so the question is, how long are they going to stay apart? Now, what we do see for mortality, all-cause mortality, is although they stay apart, we lose statistical significance. We have less people, so not a surprise. But if you look at all-cause mortality or major stroke, we actually are still statistically superior at 3 years. So that's what your patients want. They want to be alive and without a stroke, and we still have superiority at 3 years.
So what did you look at specifically? I mean, this is the 3-year data. How many patients were involved by now?
By now we're down to about 289 patients, and you know, the numbers are starting to dwindle, of course, but they're going to do that in any group. But what we've seen is that every year the mortality at the end of each year is very respectable for people that started at a mean age of 83.4.
I mean, one of the things you're talking about is improved valve hemodynamics with TAVR versus SAVR. Why?
Well, because surgeons know that we need to put in the biggest valve we can to get the best hemodynamics that we can for a number of reasons. First of all, patient-prosthetic mismatch and gradients are bad for your patients. They kill your patients. And the other thing we know is that people that start off with higher gradients have more structural valve deterioration as time goes on. So now we have a valve that actually gives me superior flow hemodynamics over any surgical valve over the entire course at every single time point. So we think that it does two things. That may be why these curves have not come back together. You remember in PARTNER 2A, they separated early, but then they came right back together and they tracked each other for 5 years. These curves separated early and have stayed apart. Why is that? Well, I think after 1 year, the impact of the procedure is done, and now you're talking about the impact of the prosthetic device used to relieve the aortic stenosis. And so these valves seem to be doing very well.
Some of the valves used in surgery seem to be smaller than what I was expecting that they would be.
Well, that's what everybody says. And everybody says, I never put in a 19, I never put in a 21. And then we run a trial with the best centers that we can find in the country with very experienced surgeons. And these are the valves we get. Now, if these are the valves we get out of experienced centers, imagine if I went to the guy who does 8 a year and what's getting put in there and what the difference might be. So, that's what everybody says. But again, the real data is the real data.
And no difference in the occurrence of structural valve deterioration over time.
Yeah, but that's not a big surprise. We're still very early. We know as surgeons that when we look at tissue valves, it takes about 7 years generally before we see a signal that they're starting to degenerate. And of course, that depends on how old you are when we start the trial. The median age for surgical trials in US and Canada now is between 65 and 70, and that takes 7 years. If you start at 83, it's probably going to take longer. So in the PARTNER 1 and the core valve IDE trial, these patients are old enough that we probably won't get an answer for structural valve deterioration other than it's not occurring early.
You have to realize, though, that TAVR has been such a tremendous success so fast that I think people are still looking at it as there's got to be a shoe dropping here somewhere. There has to be something. But so far, everything has looked awfully good.
Well, and I agree with you. As a surgeon, I keep saying, okay, where's the catch? Where's the catch?
Exactly.
So far, we haven't seen that. And everybody keeps saying, well, we can't use it in young people because we don't know durability. If you look in the surgical world, if you introduce a new surgical valve that gets approved, every surgeon wants to be first on his block to use that valve with no long-term durability. In fact, there's only a couple of valves that really have long-term durability in the surgical world. But we talk about each and every surgical valve as if they all have this data. They don't.
Now, you also have a new sub-study in patients with lower STS scores. Right. Let's talk about that one for a moment.
Well, so when the TVT first data came out, the mean STS was about 7.1, less than what we saw in the clinical trials. And so I thought, well, let's take our data and let's take people that have an STS that are 7 or less, which is going to be, at least by STS, the lower half of our high-risk group, and let's see how they do. Because my theory is that the lower your risk was, the less impact the invasiveness of the procedure would have. you're healthy, you can survive it. And really high-risk people, I can do a perfect aortic valve replacement, perfect surgery, perfect care, and they die anyway. They just don't have the oomph to recover. But as we go down, it should depend on how well you relieve the aortic stenosis. So as we move down, is surgery going to do better? Well, what we found was that 1 year, we had superior survival to surgery in this lower end of the high-risk group. At 2 years, we had superior survival to surgery. And at 3 years, which, Michael Deeb will present as part of his, it's still superior survival and superior survival or all stroke. So it's really very encouraging. And in fact, if you look at the demographics of our less than 7, it's not too far off of the Partner 2A. It looks like the Partner 2A group.
It's kind of stunning, isn't it, when you look back at what's happened in the last few years?
Oh, it's absolutely stunning. I mean, as somebody that's been doing this for 35 years, this has got to be the most exciting thing that I've seen. And it's, you walk by and you see your 87-year-old lady sitting there and her husband has just got tears in his eyes because she came back up to the room and they ate dinner together. Yeah. No matter how small I make my incision, no matter how fast I operate, I can't do that with an operation.
Yeah, absolutely. Well, I thank you very much. And the paper is online after being presented here at ACC. So look at JACC for that, and look to CardioSource World News for coverage from ACC 16, where I'm Executive Editor Rick McGuire.